Yes, thanks. I was looking for them in the... Okay, please, can you take a seat? We will start streaming and opening the session in 1 minute. So it's a great pleasure to have Philippe Meilhus, Health Economics at WHO, joining us as a former IARC colleague as well, who was very much involved in the IARC Summer School first, second and third edition, and now the fourth edition is coming as an external guest. We also have the pleasure to have two guests connected online, Dr. André Ilbaoui from WHO and also Cindy Gauvreau, who is also a health economist and former scientist at IARC. So Philippe, I'll let you opening this session. Thank you very much.
Sure. Are we all there? So, well, we may still have some stragglers behind, I think. So very well. So, hi everyone. Good afternoon. So I said my name is Philippe Meilhus. I'm an economist in the Economic Evaluation and Analysis Unit in the Department of Financing and Economics at the World Health Organization in Geneva. Very long. So that's a little bit in a nutshell where I'm from. So I basically work in a team at WHO that primarily provides support to countries in terms of everything that has to do with collecting, evaluating, as well as introducing economic evidence in policy making. So our focus is really on working together with countries to basically develop what we call health benefit packages that will fit within universal health coverage strategies. So we work on issues of value for money, prioritization, and of course taking into account health systems constraints and all the other health system building blocks that we're going to talk about today. But we also produce a lot of tools and guidance, and you will see, I mean, this is the way that I usually work. I prepare this massive amount of slides that we will go through, but some of them, actually many of them are simply resources. So documents that we have, tools that we have, and that you can basically use should you be interested in this topic, of course, but I'm pretty sure that with the presenters we have today, that is going to be the case. So in terms of what we are going to cover, so we have 3 speakers today, myself included. I'm going to cover the more generic side, the general side of things, to provide you an introduction on UHC, concept that many of you are of course familiar with, but we'll just go through it and why it is important for the discussion of today, and in particular see, since the title of the session is on setting priorities, is of course, how does prioritization fit within the UHC agenda? I'll present some more information on anything that has to do with what we call the 3 Ds of decision making, data, dialogue, and decision. And then I'll show you some of the guidance and the tools that we have, and I'll quickly go through them. So we are very fortunate today to have 2 external speakers, Dr. André Ilbaoui and Dr. Cindy Gauvreau. André will cover everything that has to do with costing and financing of cancer control programs, and Cindy will do a much more applied work, where she's going to take cervical cancer as a case and discuss costing as well as investment case analysis in the context of the cervical cancer elimination initiative. And I'm actually very happy they're both here today. So that's why I think you all saw a little bit their short bios, but I would like to provide a little bit more information about them. So André is currently the team lead for the cancer control program at WHO headquarters. So under his leadership, the cancer control program at WHO really expanded substantially and has become a true driving force of global cancer control. And we could have a separate session on showing what the cancer program has done over the past years. So I'm just going to mention a couple, and I'll also have some of the resources of that within the presentations. But for instance, André and his team edited the WHO report on cancer, which is the first ever report on cancer with practical guidance on the implementation of cancer control programs. A huge range of new technical products are also issued over the past couple of years, from guidance on cervical cancer screening to really technical recommendations for health products. One of the tools that was also developed over the past years by Andre, and that we will also discuss in a lot of detail today, is what we call a cancer module, or WHO IR cancer tool. It's no definite name yet, but it's basically a tool that allows users or countries to do priority setting, to define what interventions are the most cost effective, whether it fits within the budgets allocated by the Minister of Health, to do costing and investment case analysis. So we will look into that a little bit more detail. And of course, one of the incredible achievements has been the launch of 3 different global initiatives, the Cervical Cancer Elimination Initiative, the Global Cancer Control Initiative, but also the Childhood Cancer Control Initiative, which was actually led by Andre and is now being implemented in a lot of countries worldwide. And Cindy I'm also very happy she's here, because I used to be based at IARC before, and Cindy was a visiting scientist when I was here. So she expanded also a lot of the cancer economics work that was done at IARC, and thanks to her, we were able to develop some programs and projects. She's done a lot of work on cervical cancer while she was at IARC. She's currently a health service researcher at Sick Kids Hospital in Toronto. But one of the landmark documents that she led was the volume on cancer for the Disease Control Priorities Project, which I also advise you to go and consult. It's a multidisciplinary document with a bit more of an academic lens, but incredibly important and interesting studies that were published. And of course, Cindy has been a critical staff member who was involved as well in the economics work and the costing work for the Cervical Cancer Elimination Initiative, and is also currently the economist for one of the largest implementation studies on cervical cancer screening, the Success Project. And she's also going to be presenting a little bit on that today. So, and you see, this is one of my a skill that I don't have. I tend to talk a lot and then forget to push the button with the slides to continue. So that may happen a couple of times probably. So, and despite that, I actually type out everything, but then I don't look at it. So it's a bit of a, but yeah, anyway, I'll try to do a bit more, be a bit more structured than what I usually am. So really the objectives of the session today is we're going to look, as I said, at priority setting. We're going to look at health benefit package development. We will look subsequently how cancer control fits within that. So Andre will discuss the importance of sustainable financing and financing cancer control. And then, as I mentioned, Cindy will look more at the applied side in terms of the investment case methodology as well as costing, and that in the context of the Cervical Cancer Elimination Initiative. As I said, I will provide you with a lot of WHO resources and tools, examples, but also all the links that are used. And then, of course, later on, after the main presentations, we will have a 60-minute exercise on priority setting. It's very simple, but it's just to show you a little bit how priority setting is done in practice, and to show you a little bit the trade-offs that you need to take into consideration when looking at the different criteria, when you're actually defining which services you should be including. So let us, I'll start. So what I usually when I start, with my presentation, I always use this figure. So because it's actually a good visual representation of everything that you need to consider when you think of financing, priority setting, or health benefit package design. So this is basically what we call the UHC cube. I think many of you must already have seen it, I hope at least. It was first published in the WHO report in 2010, and it shows the dimensions along which countries have to progress towards UHC. And so the 3 dimensions. So the first one is to basically on the horizontal axis, how to increase the proportion of the population as being covered by effective services. Then we have the vertical axis is basically the amount of cost that is being covered, and which also defines the financial hardship that patients and households may face when accessing services. And then, of course, the third dimension here is what services ought to be covered in the first place. So my talk is going to be primarily on the service dimension. So, but generally, so what services should be covered and how do we define that? and then in particular also the financial side will be covered a bit more by Andre. So obviously, we would like to have all our services covered by the national system, whatever the kind of financing system that the country is using, whether it's national health insurance system or like in the UK, a national health services, which is funded by government funds. But in reality, we know, of course, that we cannot do that. We have limited resources. And so this is really about, so what do we do then? How do we define what services to introduce first? And how do we set in place a system whereby we can do that in a systematic and transparent way, and where you have buy-in from not only your government actors, but also from the whole of the population. So so many countries, in particular, when faced with scarce resources, they define an explicit, what we call an explicit, a pre-specified package of services mandated by law very often, and that will be made available to the whole population through, hopefully through public funding. And so this is then where we come to decide for the health benefit package. So the health benefit package is really the services where you know that they can be financed sustainably, taking into account, of course, the country context. And it's very important when you do health benefit package development that the included services are made explicit, so that people know the services that they're actually entitled to, that they're also made aware of what are the available, but also the unavailable services, but that, of course, they can actually access it, not only physically, but also financially. So this is then, so how do we define then that package? This is where priority setting comes in. So the definition of priority setting, or a definition of priority setting, is the process of making choices between different options to address the most important health needs given scarce resources. We always need to understand that priority setting is a political process. So it's always a compromise between different stakeholders, because each stakeholder may have different opinion on what they consider to be a priority, depending on the criteria that they would use. But of course, in general, societal values and goals should always guide the way that you actually define your services. It's really important that priority setting is evidence-based, unbiased, impartial, and should be seen as fair by all affected parties. And the reason why I'm saying that is that what we still observe in many countries, irrespective of their income status, including in high-income countries as well, is that very often decision-making or priority setting is done implicitly on an ad hoc basis. And which usually then leads to, or often leads to, inequitable outcomes and access to health services. So really at WHO, we support countries in developing explicit priority setting mechanisms, which are embedded in law, mandated by law, and which are basically systematic and transparent, and that go through a very rigid process in terms of how to define or how to assess the evidence related to the services, and then, of course, afterwards, how the dialogue happens between the different stakeholders in terms of defining what would be the most important to implement first. So the processes in priority setting and decision making are encapsulated basically in those 3 Ds of decision making. So it has 3 components, and these are the 3. This is a generic kind of framework, but it's in any decision-making process. This is what you usually have. You have a step that is related to data, one that is related to dialogue, and one that is related to decision. So the data is an assessment of, for instance, once you've identified interventions that you want to evaluate, you have an independent process of looking at the burden of disease, looking at the cost effectiveness, looking at the budget impact, but also the health system feasibility of implementing the intervention. And we will see later on an example from Thailand on how that is basically structured within their country, since Thailand is a case we use very often because it has a very well developed system of priority setting and of identifying and introducing new interventions within their health benefit packages. So once the data stage is done, the assessment of the interventions has taken place, then it's the dialogue side that takes over. This is often a committee consisted of different stakeholders who will then look at the evidence that is provided to them by researchers or by academic group or by a specifically mandated institution, and where they will then either add additional criteria to assess some of the criteria that cannot be quantified or that is very difficult to quantify, such as access or equity. And it's very important that within that dialogue, you have a transparent, deliberative process between stakeholders. It can be unstructured, or it can be done in a structured way, whereby you provide, for instance, scorings to the interventions that are being assessed, which is called multi-decision criteria analysis. So you had that. So the first you had the data, which is the assessment by independent researchers, the dialogue, then by the stakeholder group, and then of course the stakeholder group will make recommendations on what would be the services to be introduced, and then afterwards you have the decision being made, often by a representative or the Minister of Health himself. At WHO, I mean, because often sometimes not all countries already have the institutional capacity to do that kind of decision making. We also provide guidance, but generally we to make sure that when there are some general principles that need to be taken into account, in particular related to fairness and equity. And I just wanted to show you, this is actually a very interesting document that was published a couple of years ago, which basically shows the essential elements that always need to be taken into consideration when developing a health benefit package or developing a priority set of interventions, whereby you could, for instance, categorize services into priority classes, taking into account cost effectiveness, such as the dollars or the cost per disability adjusted life year that you can avert or per healthy life year gained. It should always give priority, or should try to give priority to the worst off, and of course it should provide financial risk protection, meaning that if you pay or if you have to pay for services, that it doesn't lead to financial ruin and doesn't affect your household on the long term or pushes you further into poverty. So this is all very, I mean, you've heard a lot of theoretical stuff on generic frameworks. So how is this basically put into practice? An increasingly amount of countries, and this is a term that you may encounter frequently in the literature, are basically implementing within their countries a system which is called health technology assessment. So you should not focus too much on the word technology. Technology does not mean it's not a health product. It's basically any interventions, population or individual-based intervention, as you can see on the left side, but it can also be service delivery models that are being evaluated by these boards or agencies or institutions or whatever the institutional form is that is put into place. And very often the criteria that are used within the process of health technology assessment are related to clinical effectiveness, economic consideration, budget impact analysis, but also equity issues, either at the dialogue stage or at the data stage, if possible, ethical issues, and so on. And so we see an increasing number of countries establishing those, and we provide quite a lot of support nowadays, in particular in the African region, on institutionalizing these kind of health technology assessment processes, so that they are mandated by law, but also that the stakeholder groups that are being involved are also mandated in terms of the work that they need to do for the HTA board. So we saw that the generic framework before of data dialogue and decision in HTA. This is just to show you, because I mean, if you go into the literature, it may be a little bit confusing, but the data is basically the assessment stage, the dialogue is the appraisal phase, and then of course, the appraisal phase then makes recommendations for decision on what services ought to be included in the health benefits package. But it's important that each step is independent of each other, and that there are no conflicts of interests between each of these steps. This is to provide you, as I mentioned, as I said before, when I was saying the example of Thailand. Thailand started a while ago on implementing a very systematic and transparent way of deciding what interventions should be included in their health benefit package. And so Thailand is one of those countries that has had a lot of success in progressing towards universal health coverage when they decided to roll out health insurance for the whole of the population. And so this is just a practical example to show you a little bit how it happens when you start with the phase of the topic submission, because this is not a new benefit package. It's what they call they incrementally add services to the existing health benefit package. So twice per year, they nominate or external groups nominate potential interventions or services to be included in the benefit package, which is then subsequently selected by a separate group with the first set of criteria related to the size of the population that's being affected, to the effectiveness of the interventions or the financial impact. Once the selection of the topics for evaluation has been decided, it goes, as I said, to the assessment phase. Here is either academic groups that do it in Thailand or an organization which is HITAP. And they usually assess it on 4 predefined criteria, which is cost effectiveness, budget impact, equity, and supply side readiness. This then goes to the appraisal committee, which then evaluates it, the evidence that is presented to them, and makes final recommendation to the National Security Health Office Board for a final decision to be made. And it can still be rejected, of course, at that time, but it also allows for appeals by civil society, patient groups, and other on the decisions that are being made on the inclusion of the interventions. So, of course, we always need to take, and this is a little bit to make the link as well with Andre's presentation, we always need to make sure that there's an alignment between the health benefit package design and the health financing policies in place. So benefit design should account, of course, for the use of all public funding for individual health services, and it's a central part, as I mentioned, of UHCs. The advantage of the health benefit package design is that you can establish explicit guarantees in terms of what services the population is entitled to. You can also ensure coherence across schemes if you have, for instance, multiple health insurance schemes within the country. But you can also have more explicitly and in a more transparent way define whether they are and what the level is of co-payments that the population needs to make in order to access the services. But Andre will cover a lot more the financing side of, in particular, for cancer control. So my last couple of slides, and these are quite a lot of slides. We're not going to go through all of them. So I did warn you at the start of the presentation that this is what I usually do, but it's just to show, give you a little bit of an overview on the type of guidance that we have, but also the type of tools that we have to support you. And all of these tools can actually be used for cancer prevention and control as well. So the first one is guidance. This is particular a project we did recently. It's called the Expanded Best Buys, and it provides a set of recommended interventions with very low cost effectiveness ratios, which are basically feasible in any setting worldwide, of course, depending on the country context in terms of burden of disease and whether or not it is a priority. And I will show you a couple of slides on that. We have a number of tools. So there are the main tool in our team that we're using to support countries is called the Integrated Health Tool. This is a health system tool. It allows you to do costing, cost effectiveness, priority setting, but also budget impact analysis and fiscal space analysis. It's primarily used for sector-wide strategic planning, so across policy level interventions, across diseases, across health system components. I mentioned the cancer module, which is a standalone tool for the moment, but will be integrated in the Integrated Health Tool, and Andre will talk more about it, but also allows you to do all of the different type of studies that is mentioned on the right side. We have the UHC Compendium, which is a database of a very comprehensive database, and it's becoming one of the main products of WHO, listing all interventions, but broken down to their smallest components in terms of what kind of any intervention you take, what kind of health workers do you need, what is the mean contact time between health workers and patients, and so on. That really helps you to basically develop your benefit package, or to see which kind of services can be considered for evaluation. We have the EPIC tool. I realize it's a huge amount of information, but as I said, I have a lot more detailed slides, and I'll just skim through them, but you can then look at them, and then not hesitate to send me an email if you have any questions or would like to have access to them. I can certainly provide that. EPIC, we use that. It's a tool we're currently developing to do investment case analysis. So it's looking, an investment case analysis is basically looking at the broader social and economic benefits of implementing interventions, and it looks in particular at the impact of interventions on the economy. So we use it primarily to look at fiscal space and the available resources, the resources that would require, but also in discussions, for instance, with the Ministry of Finance, because we should never forget that it's not the Ministry of Health that decides on budget allocation, it's the Ministry of Finance that decides that. So it's used to investment case analysis that Cindy will present is often used for these discussions. And then in our team, we also have what we call the Who Choice database. So Who Choice is our program on choosing programs that are cost effective. We have databases with price inputs, health service delivery costs, and any of these other elements that you actually need to do costing and cost effectiveness studies at the global level. So just very quickly on those best buys, because this may be interesting to you. So the best buys is a set of very cost-effective interventions that we recently evaluated. We evaluated over 90 interventions in total, of which 58 we did cost-effectiveness analysis across a wide range of risk factors and diseases. And of course, one of them was cancers, and it's actually Andre that did the cancer part, so I did not do it. But we come up basically with recommendations on what interventions are cost effective. In the previous, it's an update that is done every 5 years. Previously we had 16, now we have 28 interventions. And this year, because of the work of the cancer program, the number of cancers that were assessed expanded substantially. Before there was only cervical cancer, breast cancer, and colorectal cancer. And now it's a much wider range. Actually made it a little bit bigger. And so there are now a total of 8 best buys for cancer. And this is really when we call them best buys. These are interventions with very low cost effectiveness ratios. So normally any country should be able to implement them depending on the resources, of course, and of course whether or not these interventions are relevant to their country context. Most of our work is, as I mentioned, we have this database on Who Choice that you can see online as well on our website. But most of our methodology is based on our own cost effectiveness methodology, which is slightly different from what is being used in academics. And some of the applications that we have for this work on the best buys, but also other recommended interventions, is that we will develop a visualization tool, but we're also going to develop a new investment case. And Cindy is going to mention a lot more about investment cases applied in particular to cervical cancer. And this is where I'm going to start skipping slides. But this is just some explanations on the investment case side, and actually mentioned already the EPIC tool to you. So the integrated health tool, this is just a couple of words about that, because that's a very interesting tool that you can also access freely online. And so this really allows you to do impact analysis of a wide range of interventions, but also costing, and not only the cost of implementing the interventions, but also the health system costs in terms of health management information system, in terms of making sure you have sufficient human resources available. And it allows you to do predictions in the future. So if you want to expand or scale up your program, which the cancer tool does that as well, how many more health workers would you basically need to implement the program? The UHC Compendium, as I mentioned, is a database of interventions. It's also increasingly used for priority setting, and it's becoming one of the main products from WHO to support member states and countries in looking at interventions and defining health benefit packages. It's also accessible online, and it has an interface which is called SPDI. Commonly we call it the speedy tool. But if you want to have more information on, for instance, interventions and what kind of equipment, what kind of supplies you need, what kind of drugs, everything is in this very comprehensive database. So this is just another slide on the compendium. And this is where then my slides come on the resources. So we have a large number of documents and guidance that can assist countries at any level of development of where they are in their priority setting process or their decision-making process. And this is the WHO report on cancer that I mentioned at the start of the presentation. So to conclude, as I said before, to ensure broad societal support, we should always make sure that the decision-making process is fair, transparent, and evidence-based. But equally important is the involvement of a large range of stakeholders. That also includes patient groups, so that we can ensure that whatever the recommendations are, that they will not be rejected by a specific group because they have not been included. So it's to make sure that everybody agrees basically with the recommendations that are being made. And of course, as with any process, long-term sustainability is always driven by country ownership. And as I said, so we have a large amount of tools to support prioritization and health benefit package design, no matter what level they are in the development process of their priority setting. And this is just a reference of the documents that I provided to you. So Andre will now continue and he's going to talk more on the costing and financing of cancer control. So he's going to take a little bit the general information that I just provided you, a lot of information, but make it much more practical. And I think also a lot more interesting, I hope, in terms of how it's applied to cancer prevention and control and what the cancer program has been doing and also what is available to support countries. So over to you, Andre.
Thank you. Good afternoon, good morning, and good evening, colleagues and friends. First and foremost, I would just like to start by thanking Philip and Cindy. Philip and Cindy are not only dear colleagues and collaborators, but indeed they're friends. If you can, I know many of you have been in these summer courses together for some time, but just look around the room and appreciate that this is how many of our professional relationships start, in an informal gathering where people come together, share ideas about what's needed, about ambitions, and about where we can see our professional careers align. And it's been really a pleasure to have this journey with Philip and Cindy and so many other of our collaborators around the world. Second, I also just want to begin my apologies. You may be hearing some background noise, and unfortunately I had to have some travel plans changed. And please excuse me as I go through the slides for that background noise. So in the next 30 minutes or so, I'll follow up on the content that Philip had started and try to share with you some of the operational principles as we look to implement cancer control programs. So let's start with this fundamental question, which is, how can we increase access to quality cancer care? Now, that question, in fact, has two dimensions. One that we consider from the economic perspective, and as you heard from Philip, one that we look at from a financial perspective. From the economics, we are asking fundamentally, how can we spend money? What are our priorities? And when we set those priorities, how can we do so in a way that promotes equitable resource use and allocation so that we can manage disease priorities like cancer? The second question is related, but quite distinct. It's the question of financing. How are we going to pay for it? Where's the money going to come from? And how do we ensure that those financing mechanisms are sustainable, considering the growth of cancer, both the disease burden and the increasing costs of cancer treatment? So we'll take those in two separate parts. The first one is not just about the economics of cancer, but also how to priority set. An important exercise that when we look at the current state of priority setting in cancer, we see that there are major deficits. Now, priority setting is not just something we do in cancer plans. It's an activity that we undertake in all aspects of cancer treatment, control. And when we look at the mechanics behind that priority setting, whether it's in a cancer control plan, we see that many governments are prioritizing activities like breast cancer screening, but they don't have the infrastructure, i.e. the mammography machines or the radiographers to deliver that service. That reflects a lack of priority setting in a broad sense. When we look at benefit packages, as you heard so well from Philip, we see that governments may be prioritizing advanced treatment, but won't be including palliative care. That in many regards is also a failure of priority setting. And then finally, when we look at treatment standards, so treatment standards, whether they be national guidelines or essential medicines list, we can also look for evidence of priority setting in those national documents. And in many situations, again, we see governments prioritize high cost targeted therapies and not include what we would consider essential medicines. So that fundamentally raises the problem. There's a perception that cancer is expensive, cancer treatment is not affordable in countries with weak health systems, but that's not accurate. If we use this exercise of priority setting, in fact, we can accelerate access and in fact promote quality in a way that reflects the ambitions that we all have for universal access to cancer control. In order to do that, priority setting can be broken into 3 steps. So the first one you heard quite a lot about already. We have to define what we call priorities or best buys. And then the second and third steps, how do we focus on scale up and how do we look at system readiness? The best buys you heard that we now have over 20 in cancer. And these part of the whole work that we do at WHO. So governments, when they look at menus of interventions or programs to develop, they know where cancer fits as a priority in the NCD or in the broader health agenda. But what about scale up? So, of course, as you heard from Philip, it's a common scenario where year over year, an increased budget will be available for health. And if we use this scenario, which is not uncommon, we see that a government may, that more money will be available for cancer as one programmatic area. So governments are asked to take a decision. If you have to decide between should we purchase a new radiotherapy machine that uses advanced technology, or should we focus on increasing access? The answer is always increased access, because when you look at the numbers, they are always categorically in favor of promoting access. More lives will be saved and more efficiency will be achieved within how money is spent and allocated within the cancer system. The third dimension of priority setting is to ensure we look at system readiness. One common scenario, again, is governments have an inclination towards screening programs. But let's say they present with a question of, here we have a desire to detect breast cancer earlier. Okay, so how could that be done? In a priority setting exercise, if it's not done, a government may say, let's start by purchasing, for example, 30 more machines and start increasing coverage 2% per year. But when you get into the mechanics, quickly realize that that number of machines and technologies may not be needed, and the workforce may not be available to provide those set of services. So this is the exercise of priority setting. It's not just is A better than B, but it's how is A implemented effectively, and is the system ready to implement A to scale? In order to do that, and priority setting more broadly has a set of use cases, as I was referencing earlier. In the general principle, priority setting is a guiding activity. It's not an outcome or an output. Common policy documents that influence access to cancer care are things like cancer control plans, whether cancer is included in a benefit package, whether we should train more workforce, whether we need an investment case, as you'll hear shortly from Cindy. Now, these are all outputs that are a reflection of priority setting. And you heard very well from Philip that we have different tools and different inputs that support that priority setting. What's important is that when we work with governments and when we do priority setting exercises in our own communities, we start with the question of what are we trying to achieve? What is the output of interest? And what does that process look like? Because the process is the most important aspect of priority setting. Whether or not A ranks better than B is something that we can do using a basic calculation and not having any human content. But we will not achieve effective priority setting unless we also focus on the process. What are the inputs? What are the assumptions? Are the tools validated? And how does that drive toward the specific output that the government is asking us to deliver? So let's look at this in practice. This is a standard approach that there are 3 steps to, for example, in this situation, costing a cancer plan for a country. The first is, do we understand the situation appropriately? Do we know what the current health system capacities are? Once we have that information, we can then say, how can we achieve a scale up? How can we improve availability of service? And how are we going to operationalize that? And then the third is to present the information, because of course we can talk to each other about a priority setting exercise. But what's most important is that we also share that information with decision makers, whether they be policy on the policy side or on the financing side, and presenting information to them that's compelling. Number of lives saved, economic or social return, elements that we'll get to shortly. So let's indeed get a little more practical. What does that look like at a country level? So this is one country. We've now done this in 5 or 6 countries, and we have an additional 3 that we're actively supporting. This is what the process looks like. So we start with a desk review. What are the background data inputs or situational analysis about the country? What interventions have been prioritized in the past, whether they be in recent health policies or in current system capacity analyses? And then are there any accompanying related investment cases that you should build on? Because it's not difficult to generate an investment case. What's difficult, again, is to have them coherent and presented to a policymaker in a way that resonates so that they can inform decisions. Once we've done that situational analysis, then we have to agree, what are we trying to generate? Because costs are only as good as the assumptions that go into them. So a costing exercise has to have inputs like, what are we going to assume the total number of people who have care? What is the state's distribution of those people with cancer and that are a percentage of those that complete therapy? All these input assumptions determine what comes out as priorities in this priority setting exercise. Just a point of reference here to show the severity that we're dealing with in cancer. This is a middle income country, nearly an upper middle income country. And when we looked at what are the total percentage of people who have access to cancer care in this middle income country, the answer is 28%. So again, we have to take decisions. There are trade-offs. This is why priority setting is important. Because if only 28% of the population currently has access to care, we have to think, how can we increase that so that we achieve the ambition and the commitment that governments have made with the world around to universal health coverage. So then how do we scale up? How quickly can we scale up? What are the health system constraints? What intervention should be prioritized? What about quality of care? So these are the decisions that we took with the government so that we could all agree on the scenarios, the assumptions, the inputs, and then we start generating the outputs. So how much will this all cost? And that's a very important practical discussion to have with governments. What is the total amount? What is the total amount by activity? Whether it be how much will it cost for us to provide breast cancer care for all women with breast cancer in this country? How much will it cost for us to do a cervical cancer screening program or an HPV vaccination campaign? When we produce cost outputs, we itemize everything to the level of intervention so that the government can look at the numbers and say, okay, we have an interest in developing a workforce accreditation or facility accreditation model. How much will that cost? What will that look like? We want to increase capacity by building new radiotherapy bunkers and then purchasing machines. So we can present that information not only as programmatic needs or clinical needs, but you can also see we break it down as to what types of capital investments are needed. Just a few references that could be informative for those that have an interest in the economics behind that. You can see that most of the money we spend on cancer is often direct clinical service. That is paying for people who have disease and are managed in that disease. Capital costs need to be high. They're 15%. In fact, we expect that percentage will increase in countries as they look to rapidly scale up their availability of cancer services. Cancer proportional costs, of course, reflect on disease burden in the country and how they prioritize different diseases in this country. They want to focus on childhood cancer. But what's most difficult for us all to accept is in this country, we're proposing a scale up of 3% per year, which would mean in 5 years, we're effectively only getting to about 40 to 50% coverage. To achieve that, given that this country was already going to be seeing an increase in the disease burden, they would need to double how much they were spending on cancer. Knowing that, we actually went back to the country and shifted the scale up scenario so it's something more feasible resources. In addition to all of those dimensions, it's important to distinguish costs that are for, again, clinical services, like how much does it cost to pay for a woman who has breast cancer. Another dimension is the programmatic elements. What are the costs that are required to develop an early diagnosis campaign, a patient navigation network, or referral treatment standards? Those are called programmatic investments. And programmatic investments are not particularly high, but in fact have some of the greatest value for money. So part of our priority setting should also include some of those public health programs, because those are in fact high impact. And you can see in this country, there's about a third of the overall cost. We can also take that cost information and try to make it more operational for the country. Okay, we agreed you needed 5 new radiotherapy machines. You can distribute it 1 in the national center, 3 in the peripheral centers, and then 1 in a national center in a future date. These are the types of discussions that we can have, because that's the level of operationalization that governments are asking for when we do the costing. Not just give us the total amount, but tell us how can we make that a practical decision-making pathway for ministries of health and for those that finance cancer care. And one last slide, and this is a very important part of costing and financing, which is to provide the value proposition around it. Why should we do it? And that's something in cancer, we know it's obvious. When we start giving policymakers quantitative references, it becomes a little easier for us to advocate for it. If we can say, look, we're talking about in breast cancer, a third of the lives we're going to save are women who are less than 50 years old. They will have at least 2 children based on general population average. And now we're talking about a generational impact of cancer, the prolonged curse of poverty that many people with cancer are subjected to. We can also talk about how many people will avoid financial hardship, how many people won't have to sell homes or lose jobs. And of course, what is the overall number of lives that will save? All inputs that governments are wanting, as it referenced, to help motivate the discussion behind priority setting. Okay, now that's only half the discussion. The second half is, where's the money going to come from? It's easy for us to put a number on a piece of paper and say, this is how much money you need. The next question is, well, where is that money going to appear from? Well, of course, the answer is it depends. It depends on the context, it depends on the situation. It also depends how we present the information. So just for the purposes of time, I won't go too much through the core financing functions, but effectively we have to look at it through 3 lenses. How are we going to get money? How do we raise revenue? Where is it going to come from? Taxes, insurance schemes. Second, how do we then take those resources and pool them so each individual isn't subjected to the risk of a cancer diagnosis, but the risks are pooled amongst the population? And then third, once that money is available, how do we also purchase a service? Is it done through a public sector endeavor? Is it through a public-private partnership? So where's the money going to go, to whom, and at what price? Those are the aspects of financing functions that we need to consider. Now, let's get back. Let's imagine now that the government has a budget for cancer, a budget for health. We all want, and we could all dream of a situation where there's a specific budget line. This is the information from Australia that we just pulled as a reference. There is no budget line for cancer. Most countries don't have budget lines that are disease specific. As you can see here, they have a variety of agencies. But when you get into the details, start seeing that certain cancer programs are financed through the general government budget, whether it be here an example of a screening program, or here you can see that for the screening program, it was about 500 million Australian dollars. Here you see hospitals are 10 billion Australian dollars. And so you can start understanding what are the current available financing mechanisms for cancer, but again, acknowledge that there is no line item for cancer. We have to look at a variety of inputs. There is no line item in many countries for cancer medicine. It comes as part of the overall health budget for medicines, and we have to be able to understand what is it that we want to advocate for cancer medicines. And the same, of course, is true for capital investments. But that doesn't mean we should just acknowledge and step back and say, okay, these health financing dialogues are agnostic to cancer. Here you can see a very good example in Australia. It wasn't even the Ministry of Health budget, but it was in fact the general government budget that was used to finance some capital investments in radiotherapy. So it is knowing where's the money, where could it come from within governments, and acknowledging that it's not always as simple as saying, can we look at how much was spent last year and increase it 5%, but look at what mechanisms do we have to generate a capital stack or source of money that we can then use to finance cancer care. And of course, this process isn't simple. You can look in Australia, we're talking at a 466-page document with many indices and supplements that weren't captured. It's not easy, but it is important that we as a cancer community start to acknowledge that where money comes from is an important dimension of our work. Now, that's only one aspect. So when we look at revenue raising, that's what we would consider domestic pre-financing or mandatory financing for health, those that come from the general government budget. But there are other sources, whether they be voluntary, like a private insurance. And we also have to acknowledge that unfortunately, a lot of money often comes from people, the pockets, people with cancer. There's always an interest in external financing of health programs, innovative financing. But as I'll share with you shortly, we have to also be realistic about it. So is there development assistance? Can we get development agencies to take an interest in cancer? Well, unfortunately, the practical reality is that for most countries around the world, there will not be a major or a magical donor that comes and says, I will now be able to cover the cancer services. That type of ambition worked in certain disease programs, but doesn't work in health programs, unfortunately, more broadly. When we look at the proportional inputs or financing for health broadly, you can see that the more well-off the country, the more it relies on the government, which is an unfortunate curse that many impoverished populations are subjected to. Less money means more dependency on that person's family to pay for those health services. Now, what about things like development assistance or grants that come in health broadly? What proportion is available for cancer? look, I can't even show you how small the line is. I know there's a beautiful screen in that IR room, but even those sitting in the room will probably have to look extremely closely to see the small line that's attributable to NCDs. And even within NCDs, we have to acknowledge that most of it is not coming for cancer. So when we look at the overall contributions of development assistance, the harsh reality is it's just not going to be enough, which leaves us with this again. And I know this is probably the third time I've said it, but this is perhaps one of the most motivating calls to action for all of us, which is if we don't start figuring this out, the people who are going to suffer are households, families, because they're the ones that are being asked to bear the cancer burden. They're the ones that are selling their homes. They're the ones that are unable, that are incurring debt to start paying for their family members to have the cancer care that they deserve. And this is not uncommon. This happens to 50, 60, 90% of populations in most middle and low income countries. And this is not just about one person incurring debt. It's about generational debt. We started gathering data about what happens to families after a cancer diagnosis. Children drop out of school, spouses or caretakers stop working. And what we then see is a generational impact of cancer that will continue to plague our communities and our societies unless we start acting. So unfortunately, this is the reality. When we look at where is the money coming from in cancer, most of the time it's from people's pockets, and that's simply not a reality that we can accept. Now, we have to figure out what narrative can we bring to the table? How do we change this? Because we know this reality, but most people in the world are totally agnostic to it, or just haven't been oriented to how severe the problem is. So how do we start orienting the discussion so that people see that cancer is not just a disease of an individual, but it's a disease of a community and an economy? And that's one of the aspects that we're starting to work on. How do we start articulating the broader economic or social impact of a cancer diagnosis on psychosocial or subjective financial distress, child raising, etc. And then how do we build those into our investment cases so that when we give estimates on the value of cancer care, we present information like here's what the return on the investment can be. Here are the number of lives that can be saved. Here are the number of children that will have their parents and be able to stay in school because someone else besides the family decided to pay for the cancer care. All right. So that was a lot of depressing information, and I know there's not much time to present. So let me hope to set some positive ways forward. Now, when we look at financing, that's not the only dimension of a process of cancer policy or program development that we have to acknowledge. We also have to look at, are we setting up a monitoring framework? Because yes, suppose in the next day, as I'll share with you shortly, a lot of development banks are starting to take interest in cancer. Great. So they're coming to countries and they're saying, we're going to give you $100 million for cancer. That's very encouraging. Do we have mechanisms by which we're going to be able to monitor whether or not that investment yielded a return? Do we have a governance for who's going to be accountable for those resources? Do we have investments in infrastructure or training capacity that we're ready to prioritize? And again, unfortunately, the reality is we haven't yet developed that at a global scale for best practices. And without that, you will have a hard time having these investments continue year over year as development assistance becomes less available, and as banks are more reticent to give out loans or grants to certain stakeholders. So it is important that each of you as researchers, as visionaries for the cancer agenda, will be able to articulate how do we start measuring our own success? Because mortality as a tracker takes a decade or two for us to be able to say, look, you invested today, 20 years later, it seemed to work. What we have to be able to do is communicate, how do we know that an impact is achieved in a month, in a year, in 5 years, and to do that through a standardized approach. So who's going to prioritize implementation science? The harsh reality right now is most of the money in cancer is not going to implementation science. And that's something that we as a community need to continue to focus on, because that will help us justify the value proposition around cancer. So the money won't come from donors. We'll have to drive the agenda forward by better understanding how we want investments to be made and how we want to measure those investments. But again, this is the second to last slide, words of encouragement. There are a significant number of banks that are now seeing cancer as a strategic investment. But we have to get ourselves oriented. How do we want that money to be spent? How do we prioritize? And then how do we create those investments as part of a broader capital stack? Again, a term that signifies we shouldn't be relying only on banks and asking governments to incur huge amounts of debt. But how do we match those with government investments? How do we match those with international assistance, either in kind or through financial assistance? There are sustainable ways of doing it, and they're now becoming a bit more clear as how we can do that at scale in countries. So conclusions, first and foremost, quite intuitive, costing is essential. It's a process. We shouldn't just think about the number, but how we do it through a country-driven ownership-based model that involves key stakeholders through a dialogue. Second, priority setting can and should be done. Third, I didn't give very many details about what we're doing at WHO and working very closely with IARC, IAEA, and partners like SSNP. There's a lot of tools that we've now developed. There's a lot of experience that we've now been able to generate to help guide these discussions. So if there's an interest to be part of either the support to countries or the research agenda that supports or is surrounding these tools, we're always happy to have people to engage with. And then finally, let's remember that at the end of the day, if we don't do something, households are paying and suffering, first with the cancer diagnosis, and then with the long-term implications, the generational implications of the cancer diagnosis. We can rely on partners, we can rely on donors, but at the end of the day, we have to motivate our own governments and move them towards the action that's needed. Thanks.
Thank you so much. Thank you so much, Andre. I think that before we actually go through Cindy, I would like just to open the floor already for questions, in particular to Andre, so that we also may be able to release him afterwards. But, or if Andre has any questions for the audience.
So,
I mean,
I'm okay still. I can say
okay.
thank you.
Very well.
Thank you for considering that.
But still, I think we just had 2 presentations, very dense, lots of information. A lot of interesting information, I hope. But so before we go and talk with Cindy, I'll still open the floor for any debates, any questions. Just go ahead.
Okay, thank you very much for the presentation, both Dr. Philip and Dr. Andre. I'm not sure the exact person I'm directing this question to, but I just want to find out, in all that we've been saying, what's the place of vertical programs in low-income countries like my setting? Because we do all that has been said now. You do the needs assessment, you've made the, you've set the program that, okay, this is needed here and this should be done here. And then you have a donor comes and says, I want to do this here. And the country doesn't have the voice to say, oh no, we would prefer it here, and then the donor says, no, it's either I do it here or I'm not doing. And then the country is like, oh, okay, so that we just don't miss out entirely, okay, let's do it. And you find out that that sets them back, because eventually that's not what, and in the course of the donor rolling out that program, you see they draw personnel away from other programs that had been running, because maybe their remuneration is higher than some other programs that are quite important. And then you see people come out from that one, go to this one, and then eventually everything is a mess. So how do we address that? How can we mitigate that? What is the effect of that on this whole discussion? Okay. Thank you.
Thanks. Maybe when you can quickly mention who you are and the country you're from and where you work. It's just because Andre and Cindy, because Cindy can also answer questions, although she hasn't presented yet, but so that they know basically a little bit more background.
Okay, so I'm Chinelo Nduka. I'm a consultant public health physician from Nigeria.
Okay, great.
Thanks.
Andre, would you like to have a first go, because this is particularly important in terms of, I mean, we've seen that a lot, and actually cervical cancer is probably one of those case examples as well on where you do have vertical priorities set by donors sometimes, and how that's then integrated within the broader cancer control planning. Please go ahead, Andre.
Well, to start off, I think that in its own right is a lecture worth having. The first reality of public health and development is so much of the work we do is driven by donors. Unfortunately, it's not driven by domestic agenda. So there are a few things that we have been advocating for to help mitigate it, because really that was an exceptional period. It's a reality that I wish we could change. And I think we should continue to draw attention to when donor-driven agenda is actually harming the broader interests. And I have a few examples, maybe time permitting, I can share as well. But what we start really asking donors to consider is to react to existing national documents. So what often happens is that a government or Ministry of Health will be made aware of an opportunity. A proposal will be generated, and that proposal is totally disconnected from the actual national health plan and national cancer strategy. And it, by that extent, bypasses what should have been an open stakeholder process. So you had heard Philip say data, dialogue, decision, and that's the pathway that it should always, that we should always advocate for and focus on. But we often skip it and go straight to decision. And the decision is taken from an international entity and not from the national entity. So from our perspective, that's part of why we advocate for cancer control plans to be driven by national stakeholders. And as a general rule of thumb that we've been also advocating for is that until a government has its own team responsible for a cancer program, then advocating for cancer policies really should be a second-tier priority. The first thing is the government ready to own it and drive the agenda forward by dedicating a team toward the implementation, generating the plan? Once that's established, the second step is let's do a stakeholder consultative process. We're increasingly seeing the value of having things like a national steering committee, which are often independent of donor influence, so that the national steering committee can influence what priorities are set and why. And then once a plan is set, then presented to the donor as a final measure. For us, that's the general approach, which is there's no ad hoc proposals unless there's an existing national strategy that has been endorsed by the Ministry of Health. And the second is if in exceptional circumstances, say there is a new opportunity for a radiotherapy investment, at the minimum, what we advocate is that there should be cost recovery. So again, if that investment is made, there's also an agreement over a 5-year plan, and this has happened for us in now 2 countries. We said as part of this programmatic area, the Ministry of Health is expecting 2-3 people to be housed in the Ministry of Health for at least 10 years to oversee the implementation. And when they understand the cost recovery needs of investments, it makes it a bit easier for us to advocate for a country-driven process and not a donor-driven process. But there is an overarching methodology that you're referencing, and we don't have good solutions other than to invest in national stakeholders and in national processes before donors are engaged in the minimum.
Thanks, Andre. And just to add to that, and I mean, Andre covered 99%, but this is exactly what we usually do when we receive requests from countries and when we provide support. We really advocate for institutionalized decision-making processes, exactly so that it's actually, as I said multiple times, mandated. There is law and regulation behind it, so that when you have these kind of situations, we can be hopeful that they follow due process, or at least the Ministry of Health tries to bring them in the fold through participative stakeholder decision-making. But it's a reality that will still exist in some countries, of course. So, do we have another question before we go to Cindy? It's only the second day. Come on, you still have 3 days and a half to go. Nothing yet? Okay, maybe you can think about it while we hear from you should listen as well, of course, huh? But to Cindy, and then we'll open up for questions again on what Andre presented, and Cindy as well afterwards. So I'll give the floor to you, Cindy. So Cindy is really going to look very practically at taking the case of cervical cancer, looking at matters of costing, but also what Andre had mentioned during his talk on investment cases. Why are they important? What are they are? We really wanted to present you something on investment case analysis because it's a term that you encounter a lot nowadays, in particular in the field of non-communicable diseases and cancer. So thank you so much, Cindy, and I'll give the floor to you. Thanks.
Thank you very much, Andre, and thank you very much to Philippe for setting the scene, and for both of you to look at the view from a higher level and to bring forward all the important considerations that you have to make when you're balancing your decision making with a very limited resource base. So my talk is going to be more practical. It'll be a little bit more applied, but it will be within that framework that you've already made some priorities you've made some decisions, but also you're still trying to, make a clear case why this is important to your government and how you're going to go about doing it. And the cervical cancer elimination initiative is probably one of the biggest initiatives that is pretty well funded now. And I just wanted to add a little answer to our guest who asked the question, how do you prevent these well-funded WHO and donor-driven projects from taking over your health ministry? And I want to touch upon Andre's comment that implementation research is needed when you start these projects, because often you can't, you have less say in how they're implemented. There needs to be some way to capture the effect on the health system and the economy in a systematic way. So I highly advocate more implementation research, and I will actually get to that in a little later on. So, oops, let me just start this. So I'm going to start with just going to talk a little bit about exactly what is an investment case. Now, it's a type of benefit cost analysis similar to what Philippe has already mentioned and what Andre has already talked about as well. So it's an analysis where you balance the benefits and the cost of what you're doing. So it quantifies those in monetary terms, and the perspective is usually over the long term. So you have to know what the impacts of your intervention is going to give to balance it against the money you're putting into it. But you can also include qualitative aspects, because that's important too, because economy isn't everything, right? But it's actually not an evaluation because it doesn't compare it to another intervention. So already you've made that decision, hopefully, that you're already that you've taken a look at some of the other interventions and that this is what you're going to settle on. And this might be a good case, or a good project, or a good implementation, or a good strategy to follow. So you have to speak to your audience, of course, because the audience is the one who's going to have the decision-making power to actually put this into effect. And it could be the governments, of course, firstly, the governments themselves, the ministries of health and finance, but also it could be external funding bodies. And investment cases can have different objectives. You're to mobilize those resources that you don't have already, but it could be used for advocacy. And most importantly, it could be used for strategic and implementation planning. And so when you put together a national health investment case, there are several things that you need to consider. And say we're driving towards a report, a package you're putting together for the Ministry of Health and Finance. So is this an effective strategy? Is there evidence to support this? Is it cost effective? And compared to the status quo, is it going to give you good value for money? And this is where the best buys that Philippe has mentioned already can help you sort this out. Is it considered a best buy from the impact it's going to make on the disease burden? And will it give you, is it already proven cost effective in other locations and settings? So then you still need to know how it will affect your finances internally. So where will the financial flows be diverted or come from? Andre has talked about that a little bit. And will it yield an acceptable value of, compared to what the cost the ministry has to incur? And then, of course, what are the ripple effects of this implementation on the other parts of the economy? What's going to happen when you achieve these better health outcomes? And then the impact on equity is very, very important. how are populations going to be affected in your country? Are there certain populations you want to address for specific reasons? And will they have a better or worse outcome under this implementation than another population? And then, of course, other parts of the report can include the risk of not making the investment. Say you have the capacity to make a counterfactual case, and then feasibility of implementing the intervention, so the operational aspects perhaps, and then how acceptable is it to the women and patients you're going to address. And I'm talking about women because it came within the cervical cancer setting, and of course the healthcare providers. So WHO has a fairly well-developed methodology for investment cases. It has a framework where it does include that wider perspective, what the impact will be on the wider society. It's methodology that's constantly evolving as new research and new methods comes into play, and they're working together with UNDP to sort of refine it and to put it into guidance documents for those who do want to undertake their own investment cases. And you can see here there are two specifically focused on non-communicable diseases. And there's a couple of examples here also of the application of this methodology. So, and Andre has also mentioned that there is support from WHO for the creation of investment cases. There are highly capable and dedicated specialists to help sort out some of these questions. Now, going to the Cervical Cancer Elimination Initiative, you probably have had already quite a bit on this, so I won't go through what it is, but part of the adoption of the initiative by member states was based on the investment case. So this was made with the assumption that there will be a simultaneous investment in the three pillars of prevention, right? And on vaccination, on screening and treatment, pre-cancer treatment, and cancer management. And so the flow of the analysis is that all the health impacts were estimated, and these were done by two modeling teams that were part of the initiative, I guess, analytical team. And so the impact on incidence and mortality were calculated. And to those, the economics team put price tags. So, and to try to quantify it in dollar terms. And the main categories that they categorized this in was the economic benefits, which was expressed in how productive women would be if they were not sick nor had died, what contribution they would make through their labor and the economy. But also, and it's very important to remember that women who are not sick nor have died contribute in many other ways to the economy through childcare raising, through volunteer work, by their, just being alive gives them also hope and gives them psychological well-being. And so this is a very key important part. And this methodology to estimate this social return has evolved over the last 20 years through several groups of academics, including those at Harvard and University of California, and various other groups have contributed to it as well. So it's a well-defined methodology used by the Bill and Melinda Gates Foundation to estimate their returns on the huge investments they have made in health as well. So the outcomes of that was that in the 10 years leading up to 2030, which is the target for the initiative that you've heard of, it's going to require $10.5 billion to scale up. And most of that needs to be borne in low-income countries, or I should say the impact is that going to fall on low-income countries, where their lower levels of coverage and infrastructure development will require much more investment. So for low-income countries, that's going to require 40 cents per dollar per person. 40 cents per person per year in the next 10 years, compared to half of that in the middle-income countries, lower middle-income countries. But most of that is going into screening and treatment of, most of that's going into vaccination, which is why you see that first year is such a high, there's a huge impact on the investment requirements, because there's going to, the assumption is there will be a big increase in vaccination, including catch-up programs for all those who had not been previously vaccinated. And that is the most cost-effective strategy to achieve those targets, is vaccination. So $10.5 billion is a lot of money, but the return on that investment is also substantial. So by 2030, it's estimated that 300,000 women's lives will be saved and 100,000 cases avoided. And those women will add $700 million to the world economy due to their ability to work, but it's also going to add $28 billion due to this indirect economic benefits that I had mentioned, the social dimension, the contributions that they will make to the economy through being active and participating and raising children and contributing to other parts of the economy. By 2050, when we look at it farther out, each dollar that's invested in this strategy is going to return $3.20 to the world economy. And this is, I should have backed up to say this is based on analysis of 78 low and middle income countries. But you can see that low and middle income countries can also make a huge impact on the world economy. So they're going to, this investment will return $3.20 to the world economy. If you add on the social benefits, it's going to add, for each dollar invested, $26 to the world economy. So I'm going to switch gears a little bit now and talk about costing, which is the basis of almost all economic evaluation. It's very important, and both Philippe and Andre has already touched upon the place of cost. So I'm of costing and cost. And so I'm going to just go into a little bit more detail about how it's done and how it's been applied in the cervical cancer elimination initiative. So I want to start off with saying that cost data collection is not a haphazard activity. And to do it properly, there are guiding principles to help out. And this reference case for estimating cost of global health services and interventions was put together by a consortium of Harvard economists and London School of Health and Tropical Medicine, and as a project. And it provides sort of a Bible for costing. And it derives from good practices that are already existent in the cost effectiveness and economic evaluation field. So it's within that principle of good, sound economic theory, and with application in with compliance and adherence to those principles. And so I encourage you to read it if you can, maybe when you can't sleep or something, but I just want to let you know that there are principles for doing this well and to do it better. So but it is not a how-to manual. So you can, you'll have to look to other tools for that, but this should be your background. So it'll help you sort out what the scope of your costing work would be, you know, who and what, the audience, how to address those audiences with the proper methodology and analytical methods, and what the types of economic analysis are, so you can match those to your audience as well. So again, why do we do this? It's the foundation of all economic and financial analysis. And what it helps you to do is to identify the resource needs, first of all, so you can spell them out explicitly, and then try to put a cost or a value to the health services that you're delivering. And this is critically important for developing your comprehensive national cancer control plans. You know, Philippe has already, Andre has already touched on this as a, you know, a priority setting consideration. And so there is need to do this well. It will inform the strategic investments in your country, so you can make a better priority setting decision, as well as inform the programmatic budget, so that you can know what the impact of these planned interventions are on your financial flows. For the elimination initiative, for countries that have committed to it, and most of the members of the WHO have committed to it, it can support the development of country-specific investment cases in line with the targeted scale-up of services. And those 90-70-90 targets may not be achievable by most countries, but most countries can set their own targets. And this is what you'll have to gear your investment cases to. So, of course, most countries won't have enough resources for this. So the investment case is an important tool to do this, and underlying the by good costing. So some of these terms that you see in front of you are very basic, and I'll use some of those, but opportunity cost is something economists care about deeply, because it is, of course, a decision that's made with a scarce resource base. So you have to decide between one and the other. And of course, when you decide on one intervention, you're losing resources in another. Economic and financial costs, you sometimes there's problems sorting them out, but you can think about whose costs are actually being accounted and separate them that way. So economic costs are incurred by everybody who's involved in the intervention, whether or not you're actually in the country or not in the country. And it's what economists would consider the true cost, because it's all resources put together, incurred by everybody who is either providing financial in-kind support or volunteer work, for example. The financial costs are the ones you actually see, the ones that are paid out, you know, in a check or in a money transfer that actually shows up in your accounting ledger. And these can also be divided up into financial costs versus expenditures. So when we say financial costs, often those are smoothed out over several years, but expenditures are what happens in each year. So that's actually the payment you make that year. So one example is for capital equipment, of course. So that's a huge hit in the year that it is actually bought. But in a financial analysis, you can appreciate or depreciate that over several years, and so smooth out your spending pattern a little bit. And that's critical to understand that when you buy very expensive equipment, when you make your financial analysis when you make your investment case to have it all not lumpy. And so you can have a better idea of what your flows will be. Unit cost refers to either a unit cost of an intervention or a service or an input. So it depends on the level of your analysis. You can define that. But also, if you start with the inputs, you can aggregate that up. So for example, we can say the cost of a syringe for vaccination, but then you can go to the cost of a girl vaccinated, which would include that syringe, but other services that are provided. And then, of course, you can go to the unit cost of vaccination versus the cost of screening and treatment, for example. Direct costs are those that are directly attributed to that intervention. And those are the ones that are mostly visible, as you can see. But indirect costs are very important too, but they're not using the health resources, but it could, but they still have impact on the economy, right? So for example, the productivity loss of being sick or the out-of-pocket charges that are made to women for accessing that service. So WHO has two specific tools that are important for supporting low and middle income countries. One is the integrated health tool, which I won't speak about because that's been covered, but I just wanted to draw out that the costing in that tool is very important because it will give you a chance to cost out several cancer interventions at the same time and also analyze it against the budget flows for those other interventions, and so get a better picture of the whole picture of the whole flow of sector-wide financing. And so I'll speak a little bit more about a cancer-specific costing tool, which has been developed at WHO over 10 years, maybe 12 years now. It's evolved. And there are two modules that are in play. One is for vaccination, and one is in screening, precancer and invasive cancer treatment. And these can be used to make projections of expenditures and finances and resources used, or it could be used retrospectively to see what has happened in your program. And this is for the medium term, 5 years or 1 to 5 years. So again, it's not necessarily something that you would use for making your big picture decision, but to narrow in on your small picture decision making. Philippe has mentioned that there's a large, well-funded project, and I had touched on that earlier. It's being funded by UNITAID in support of the Elimination Initiative. The Success Program is part of that funding. And in that project, we have a consortium that is led by Expertise France, which is a technical aid agency from France. Tropigo, a well-known nonprofit that has implemented many, many projects on the ground. And of course, UICC, one of the main advocates in the world for cancer control for low and middle income countries. So the Success Project is working with the governments of Côte d'Ivoire, Burkina Faso, Guatemala, and the Philippines in implementing and studying a strategy of scaling up secondary prevention by integrating it into services that already exist. For example, HIV services, especially in HIV endemic countries, and in women's services through, say, mother and child clinics, wellness clinics, and other clinics that are identified by the governments where there are many women clients. So costing in the Success Program is for the development of a transition plan to do real world feasibility and comparing the resource needs across various scenarios. And in this project, we're concentrating only on the screening and treatment of precancer treatment. So we have how it works is that it engages the local economists and analysts in a collaborative and iterative cost collection that aims for transparency and reasonableness and reproducibility. And so it is an Excel tool, and it has financial and economic costs from the health system perspective. You can cost in the local currency and US dollars, and it allows French, English, and Spanish analysis. And it uses an ingredients approach. So identifying all the sub-activities, all the ingredients that go into that sub-activity and costing each one. And where possible, we've provided pre-populated data. So this is just what it looks like. So in here, we have a sheet of inputs for cervical cancer, for example. This is something you can see by the drop-down list that this is where the pre-population occurs. And then the output is a one-page summary that mirrors the country profiles that WHO has on its cancer platforms, and you can change the inputs through the services or the scenario. So you can try out different ways of implementing secondary prevention. So sorry to rush you through this, but we do want to get questions from you. So again, costing is vital to achieving cancer prevention and control targets. High quality investment case need good costing. Costing is a process of planning. It's not an exercise on its own. And tools are available to help countries do this. So, there is a place to start for all of this. And I thank you for all. I've heard that you're a very active and engaged and enthusiastic group. So we're looking forward to questions from you.
Thank you so much, Cindy. We have time for 1 or 2 questions, and we have 2, so 3 even. Go ahead.
Hello, my name is Dr. Mirza Muhammad from Pakistan. I'm a clinical oncologist. Thank you, Cindy, for the wonderful presentation. I just wanted to ask one question, and first I will give you a little background of the question. In Pakistan, we started a health facilitation card in 2016. Initially, it was covering only the population who had $2 per day income. So later on, in 2022, almost whole population of the one province and later on of 2 provinces was covered. So keeping in mind the universal health coverage advocated by the WHO and decreasing the out-of-pocket expenditure, it was started, and right now all the services, health-related services, are covered by them. The model of it is the provincial government pays the insurance company premium of all of its citizens, and then the patients go to hospital, and the insurance company pays the hospital the amount which is used. The amount covered is almost like $3,500 per family per year. And oncology services are also covered in it. And almost all of the treatment, radiotherapy, chemotherapy, it is covered. So our out-of-pocket expenditure has significantly decreased by this program. I just wanted to know, do you know of any other program like this one? And what was the long-term outcome of such program? Thank you.
I think that's a question for Andre to answer.
Yeah, thanks, Cindy. Indeed, there are different financing mechanisms that countries have used to start improving financial protection. One country that had used that model is Kenya. So Kenya in the past had covered a sum total of hospital costs, usually in the domain of certain aspects of cancer diagnosis and treatment. So it's generally focused on cancer treatment, and it's now been in place for about 5 years. The model does work. One of the challenges has been that it doesn't necessarily inform what services should be provided. And in that regard, it is less likely to, let's say, streamline provider practices. And there are some inefficiencies that are unfortunately a consequence of variations in clinical practice because of challenges like what products will be procured and who's responsible for procuring them, what service availability should be prioritized, like radiotherapy, and how do we generate net investments in those priority areas. So it is, as you said, assuredly better than no general government expenditure and cancer or direct contribution to cancer. It's difficult to say whether or not it's an inferior or a superior way, but it is a starting point. The other approach that different governments have used is to focus instead on select cancers. So, for example, in Mexico, China, there was initially a focus on things like breast cancer or childhood cancer as a first strategic. So rather than pay all cancer, the cost of all cancer diagnosis and treatment for all cancer types, they would focus instead on select cancers. That has seemed to work. It's difficult again because with such small numbers, we can't generalize as to what approach is best. But what we have found is that governments, when they start investing in cancer, began to see the return and the favorable, say, public response to those investments overall. So yeah, maybe I'll stop there. They're just taking note of the time. But it is a model that I would appreciate from the perspective of improving access to cancer care, but still note that there are some risks that have to be considered in the medium and long term.
That's doing is we're going to ask the questions. I know you want your coffee break, but you can have your coffee break during the first part of the exercise. So is that not a wonderful idea? Very well. So you can have your groups do your first part of the exercise and drink coffee at the same time so that you can have the two other questions that we have. Go ahead.
First of all, thank you for your great lectures. I have a question. I don't know for each of you.
Can you please tell us your name and where you're from?
I am Dr. Ariwan from Iraq. I am radiation oncology resident doing my board certification currently. So my question is that for action plans or opportunistic cancer screening programs, it's a demanding problem. It needs capacity building at government level. It needs a huge budget most of the times. So what do you think about outsourcing screening programs and implementation of action plans of specific cancer sites or cancer at a national level for different sites of cancer to third parties, outsourcing it to third parties, that the third party companies would be utilizing the infrastructure of the government and the health infrastructure. Would you think it would be possible? And because I think sometimes the problem is not only the economy or the costs of providing the budget or funding. The problem is difficulty in coordination between different departments that will be incorporated into running the system. Maintenance is one of the major problems, and capacity building of a huge number of people that would be involved in that program. Would you think it is possible? Because when you outsource something with collaboration with the government and using the infrastructure, they would be responsible for the planning, they would be responsible for the capacity building, and the government in that position will just give money and look for and observe for the progress of the program.
I think that's another one for Andre. Very popular as usual. Go ahead, Andre.
No, so indeed, it's a great question, and I think all of us can have a comment on that. The general experience that we've had with outsourcing screening services is that it can work at a smaller scale. The problem that we have experienced, I shouldn't say always, the problem that has been experienced is the fragmentation. So it may be that a service provider, whether they be in the for-profit, nonprofit, and within nonprofit, including civil society organization, when services are provided through those entities, there is a disconnect in when is responsibility then transition. So one of, let's say, a civil society organization initiates a screening program. Will they continue until the pre-invasive disease is treated? Will they continue with the diagnostics of the false positives? Will they be responsible for the communication of the results? And at what point do they then transition on responsibility to the government? So it is a model that, in fact, many governments use because they don't have the infrastructure or the administrative requirements. The screening programs are very administratively heavy. They need dedicated information systems, dedicated administrative roles and responsibilities. And so it is quite common in American countries that those services are outsourced. It's the coordination that becomes difficult. So if such approach would be considered, and we've seen it both successfully and unsuccessfully, there has to be very clear roles and responsibilities to who is then accountable for when X or Y episode happens. When it's done in that model, it can be done efficiently and in fact improve access. But as a general practice, we don't recommend it because we haven't yet seen it successfully deliver at a population level, because most of the civil society organizations have a scope of work that's limited to a specific area of a country and doesn't help cover the vulnerable populations in rural areas, etc. But it is a very compelling opportunity. So I wouldn't suggest ignoring it. It's just that stipulations have to be drawn around them for the programs to be done.
Yeah, I'll just add a little bit to that. And you may want to consider what specific part of the program can be outsourced. So for example, in the Success Project, which is scaling up HPV testing for primary screening, it's we found that the central labs don't have the capacity all the time to do to process the tests, and some private labs have been involved, and that has worked very well. But again, it's Andre said, it was coordinated by the Ministry of Health, and they were already partners doing other types of lab processing. So worthwhile looking into some of those things, but again, taking notice of what Andre has already said.
Thanks. So we have one last question, but if you could be short about it, then.
For gender balance, I'll ask Cindy. I'm Dr. Ishaq Lawal, a gynecologist from Nigeria. The question is about this C4P tool that was used for Sussex, and you showed this Excel where they'll just make inputs. It looks fascinating. I just want to know if there's opportunity for technical support for countries like Nigeria, but at the subnational level. Because one of the challenges we have in Nigeria is that we take Nigeria as an entity, and we have 37 states in the country. So the last cervical cancer strategic plan was costed at national level, but it was never implemented because implementation happens at the state level. So is there could there be opportunity to have such Excel that can be for the 37 states so that we can see what is required at the subnational level and we can monitor progress at subnational level? Thank you.
Yes, that's a great question, because often that's how strategic plans are rolled out in specific region, and then they're scaled up to other regions. And so the C4P tool is able to do that, because even though it's meant for national planning, you can specify the population within a country as well. So as for technical assistance, the C4P tool that's being developed under the Success program is not ready for wider release, but it will be going back to WHO. But Nigeria is actually involved in the UNITAID initiative, and I'm not sure who your contact is within for that project, but a request can be made to that project. It's run by CHI, implemented by CHI there, the Clinton Health Access Initiative. And then a request can be made to Unitate for use of the C4P. And then, you know, we can collaborate at that level as well. So CHI and the success team are working together, for example, in Rwanda, which is, it will be a joint programming, a costing exercise. So we can talk about that a little bit later, but there is a mechanism to do it in the short term, but also for the long term. So thank you very much for that excellent question.
Thanks, Cindy. And I think we have an intervention as well from Sharon, who wants to add something.
So Nigeria is actually one of the countries that we've used the C4P, and I think Andre wanted to say that as
Yes.
WHO. If you go online, you'll find the technical document, costing for the National Strategic Plan for Cervical Cancer. I know that Zambia got technical support from WHO Nigeria, but we understand Nigeria has got so many states and everyone has got, so there is capacity already that Nigeria has used C4P that WHO has. They were one of the countries that was piloted.
That's right. I was involved in that initial costing, and it would be great to take it down to the subnational level. So it's, you know, oh, I think Andre wants to say something.
No. I was just going to say one quick thing, but the most important was to acknowledge that Sharon is in the audience, and yesterday was Sharon's birthday. So I know you don't have a lot of time, but it maybe if we could at some point sing happy birthday to Sharon. And I don't propose taking the lead on that since my microphone may be louder than others. But happy birthday, Sharon. It's nice to see you. The second is, I think one of the great things of this having links to the IARC summer school is because we talk about technical support. In the perfect world, we want these tools to be used at the country level, as the other colleague from Nigeria raised, by country stakeholders. And so please note that within WHO and with IARC, we are going to be looking to find ways to train people so that they themselves will be able to use these tools at the country level. And we've been engaging a few donors to see how that could be possible, because these, again, Cindy said it perfectly well, the process it's a process and it needs to be country driven. So the best scenario is that we create tools that are usable and driven by country level stakeholders. But anyway, it's great to see you, Sharon, and thanks for this.
Well, it seems we're warming up for more discussions, but unfortunately I have to stop it. So I would just like to thank Andre and Cindy for making the time available to be here with us today and giving these wonderful presentations and interventions. And I think we should give them another round of applause, of course. Thank you so much. And then I think we will just continue and